All right, let's get started. So welcome everyone. My name is Phil Englevich. I'm an associate professor at Bloomberg School of Public Health and a deputy director of the Gates Institute here at Johns Hopkins. And it's a great pleasure for me to introduce Dr. Fred Makumbi as our speaker today for the William H. Gates Institute for Population and Reproductive Health. Dr. Makumbi is an associate professor in the Department of Epidemiology and Biostatistics at Makerere University. Dr. Makumbi received his bachelor degree in statistics from Makerere and master's in health science, and then moved to Johns Hopkins in 2004, where he got his doctoral degree here at the School of Public Health. Dr. Makumbi's training at Johns Hopkins focused on was supported by the Gates Institute and the NIH. And Dr. Makumbi has extensive ties with Johns Hopkins overall. So he's led the Uganda country team for Performance Monitoring for Action project that monitors change and explains change in family planning indicators. He's also led a Uganda team for USAID funded project on research for scalable solutions, R4S, and is a member of family planning working groups, equity steering committees, national self-care guidelines groups in Uganda, safety monitoring team, safe male circumcision for the Ministry of Health, national demographic dividend steering committees, National Population Council in Uganda, and a whole range of other leadership positions in population, reproductive health, and public health in Uganda. So overall, Dr. Makumbi has a broad range of research experience, ranging from sexual reproductive health, orphanhood and HIV, evaluation of health programs, clinical community trials and design, statistical analysis of surveys, and HIV interventions. And he's widely published in peer-reviewed journals in these and other areas. So overall, we're incredibly fortunate to have someone with the scope and experience who can speak to family planning, reproductive health, and public health more broadly in Uganda. So I'm sure we're all excited to hear more about Dr. Makumbi's experience and vision, and also his thoughts on future public health issues in Uganda. So thrilled to have you with us, Dr. Makumbi, and now we'll move over to your presentation.
So thank you so much again. Good afternoon. My name is Fredrick Makumbi. I'm from Makerere University School of Public Health. I'm specifically from the Department of Epidemiology and Biostatistics, where I'm an associate professor at the Makerere University School of Public Health, Uganda. So I would like this afternoon to quickly share with you my journey, training to research that I've been involved in over the past 25 years, and how that has been able to go into policy and practice with a focus in global health. But we shall certainly mainly focus on some specific areas of global health, and I will dwell a lot in sexual reproductive health and family planning. So I'm glad to be here again. Yes, so, but again, maybe to give you, paint a picture a bit, there's been a lot of collaborative research and training between the Johns Hopkins and Makerere University School of Health. And this has been over a number of years. There's been a lot of collaborative work which is being done. And previously worked with a number of faculty here, Robert Bollinger, David Peters from International Health, looking at innovative approaches to build capacity at African universities that would go ahead and improve health outcomes. And these are shared. And some of the areas that we focused in have been in areas of maternal and child health. I know we had a training program with Johns Hopkins over since 2009. We have conducted a study to try and see how innovations like transport vouchers could enhance and improve the health and well-being of mothers and their children. And recently, about 2 years ago, we also received visitors from Johns Hopkins, again, with colleagues here working in one of our demographic sites, looking at how digital platforms can be, again, used to further enhance and strengthen health services. And by the way, also other colleagues who have worked with Johns Hopkins and Makerere University have been in areas of injury and trauma. And there's been a recent piece of work that has been shared looking at use of head helmets. We have a number of borders or motorbike in Uganda, and exposure for injury is really so high. So there's been a lot of work done, maternal health, injuries, use of digital platform, innovations for capacity strengthening, for improving health outcomes in Africa. This work has been done between Hopkins and Makerere University. In 2010, we got funding from the Gates Institute, where we developed a center which was called Family Health Research and Development Center. And this was inaugurated by the then Vice Chancellor, Professor John Dumba. And we did a lot of work using the funding from here because it was meant to build the capacity, research capacity, and also providing leadership in the area of data management, such analysis for reproductive health, research, and implementation science. So this, like I said, again, this center received funding from the Gates Institute towards enhancing those skill sets. This being a training institution, the area of data evidence generation was kind of weak, but again, this is one of the areas where this funding has been very helpful. But also, this funding supported us to get stakeholder engagement, and we have been involved in a lot of country-level stakeholder engagement. My team here in 2012, we went out to join the World Population Day celebrations in one of the districts in Uganda. That came after the 2012 FP Summit in London. But as again I said, strengthening data management, research in reproductive health, this funding came with research awards to students who were in the supporting and working in reproductive health. And the dean at that time was passing over this award to that student. Work has not yet ended. Collaboration between Hopkins and Makerere University. We've recently received 1.1 million US dollars through the American Schools and Hospitals Abroad programs, again, through the partnership with Johns Hopkins University. And this was through the partnership leadership of Professor David Peters. I think it is International Health. And this money has been used to construct the new home for school public health. And one of the spaces in there is providing health services, especially family planning and other health services to the communities around that new building. Very helpful, important, and again, this is part of the collaboration that we are seeing. But I think I'll slow down a bit and I tell you my story. You'll pardon me, I won't start from my primary, but let me begin from undergraduate. South Africa, Uganda is in East Africa, part of East Africa, one of the countries. And there's a university which I went to, one of the primary old universities, Makerere University, where I went to do my training. And my training was in statistics, applied statistics, where I graduated in 1993, over nearly 30 years ago. And that building, by the way, was brought down by fire. And I think there's a lot of construction going on now. But that is the symbol of Makerere, which was built in 1922. But that's where I got my undergrad degree. When I finished my undergrad degree, I had the opportunity to go and work in a research organization called Rakai Project. And I had to make a choice because I had got a job in the bank to work as a bank teller, counting money, which was not my money anyway, counting money. But I sat with my grandmom, whom I grew up with, and she told me, just go ahead and join the work for which you trained. And I had a lot of interest in data. So I joined Rakai Project, which is again southwestern part of the country, Uganda. And it's the epicenter, importantly, it's the epicenter for HIV/AIDS in Uganda. With the first publication, 1985, as indicated. So in Rakai, I went as a data collector, interviewer, if I may. But later on, I became a core team leader, managing a team of adults. I was the second youngest person at the age of about 22. The rest of the team members were much older than us, nearly 15 years on average older than us. But then I was given an opportunity to work with that team as a core team leader. And at the time we were studying the dynamics of HIV/AIDS and the role of sexual networks. So much about HIV was not known at that time. In 1997, yes, I think 97, I had the opportunity to come to Johns Hopkins for the summer program, and that really excited me a lot. So 2 years later, 1999, I had the opportunity to come and get admitted at Johns Hopkins School of Hygiene and Public Health at the time. That's what it was called. But I came out as special students because we are required to do GRE, graduate record exams, which I did not have because at the time they only provided in South Africa and Egypt. But I never had the opportunity to do those. But because of my training in the summer program, I was allowed to come in as a special student who later transitions to a Master's of Health Sciences degree. But also the school, within, I think, 2 years, it transitions to Johns Hopkins Bloomberg. So one of those few people who have been in two spaces, School of Hygiene and School of Bloomberg School of Public Health. So I got admitted in 92, and then, like I said, I was able to, 1999, I was able in 2000 to graduate with a Master's of Health Sciences. And immediately I had opportunity, again, with the funding from NIH Fogarty and the Gates Institute funding, I was able to join the Ph.D. program. And that scholarship, those two scholarships really projected me to the new levels, which I subsequently got into. So I ended up graduating in May of 2004 with a PhD. I never made a stop when I came in as a special student to Masters of Health Sciences to PhD, again, working very closely with the support and funding from Gates Institute. And Fogarty was mainly, again, for both Masters and as well as the PhD. I gained a lot of skills. You know, I had only worked for 5 years in Rakai, data collector, then data manager. So much I did not fully appreciate and know. I had a practical sense in the field of research, data collector. But then I needed skills beyond being a data collector and a simple data manager entry. So the training in the Department of Population helped me, and family health, got me a sense of the population studies dynamics, epidemiology, the biostatistics, because my background was in statistics. So all these were exciting. And one of the professors who passed on, Professor Naston in the department, persuaded me to make sure I do some social sciences courses. And I did some qualitative courses in Hopkins, which was extremely helpful for me to be able to put meat around the numbers I get in AP, Biostat, and population studies. But I also learned the partnership and collaborations because Professor Ron Gray and Maria Wewa, Professor Amichoy worked a lot in Uganda. And so I could be able to tell firsthand from Hopkins how the team was working with the locals. So I got a sense of partnership and the importance of collaborations. And they really mentored me well through this period. And so for my PhD, the work I did was on the impact of HIV, of parental HIV infection. At the time in 1999, I think the highest HIV prevalence I saw was along the international Trans-African Highway in Liantonde, again, southwestern part of the country. It was as high as 40%. So for the new generation, which sees HIV prevalence of 5%, they may not fully appreciate how bad, impactful HIV was at the time, resulting in too many children losing their parents. So I picked interest to get a sense of what is the contribution of HIV in generating orphans. Orphanhoods, of course, resulted into so many challenges, socioeconomic impacts. uninterrupted pregnancies, school dropouts, and all that. But also wanted to see how much does HIV contribute to children not staying with their biological parents. In Africa, we have child fostering, meaning children can grow up with other relatives. But what was the impact of HIV on that as well as child survival? Again, this was focused in the Rakai district. So that's where my PhD was at the time. And this was a very important piece which was needed by World Bank and many other teams to see how could they mitigate the consequences of HIV, especially beyond the individuals, but also to the children and others around them. So that's where my work was, and we shall see subsequently how that has been able to continue and support other areas of research. Rakai Health Sciences Program, moving away from Rakai Project as it was called, there's so much that has been going on in that part of the world. Observational studies have been conducted, trials, treatment of HIV, STIs to prevent HIV incidence. That's a place where the male circumcision studies were conducted to prevent HIV transmission or acquisition, basic research, clinical care, the training. Rakai Project or Health Sciences Program has trained over 50 masters and Ph.D. and many others undergrad, and through scholarships again, and many of us have trained at Johns Hopkins. So much work has been done in the cohort that has been generating data for these studies in Rakai. And I said many of the things I learned, the mentorship. There are two senior colleagues, senior professors at Makerere University under Rakai Health Sciences Program, Professor Nelson Swankam and Professor David Sorada. Professor Nelson has been a principal of the College of Health Sciences, where the School of Public Health is located. And Professor David Sorada has been a professor and a dean in the School of Public Health. So these two professors are now professors emeritus at School of Public Health, rather at Makerere University. But also very importantly, again, like I said, collaboration, partnerships. Again, we have other two senior professors at Hopkins. My understanding, Professor Ron Gray retired, and Professor Maria Wewa were in the department, again, of population family health. And these have been our mentors and partners and collaborators with the School of Public Health, or rather with the Rakai Health Sciences Program, and also School of Public Health. Like I said, Rakai Health Sciences generated a lot of data, one of which was circumcision, and I kind of flag out only those areas where I've been heavily involved. I was in a country statistician of a trial which is supposed to be blinded to the investigators. You shouldn't know who is in which arm. But I happen to have been the only person in Uganda who was unblinded, which arm study participants were. Those circumcised, those uncircumcised, so I could look at how the outcomes were developing. And then the other person was Professor Larry Moulton, again at Hopkins, in I think international health was the only other person. So I was involved in here, but again, as I said, my involvement in research and how that has impacted on policy and programs. So the results from circumcision showed a significant reduction in HIV acquisition, and WHO, as we all now know, and UNAIDS took up this and made recommendation, again, based on one of the studies, circumcision was this, generating that. But then also went ahead as an individual investigator to try and see, for those who don't get circumcised, is it then possible to have a role of hygiene? What happens if they wash after sex? So I did analysis there, and I showed that post-coital penile washing did not, among the uncircumcised, it certainly did not necessarily mitigate HIV acquisition. There was no much difference between those who wash and those who don't wash, but washing tended to increase the risk of HIV. But so much remains unknown in this space. So again, I was an author with my mentors at Hopkins. But as I indicated, I did work in orphanhood and the incidence of orphanhood due to a parent HIV infection, made recommendation to make sure that parents who are infected get the treatment they need. ARVs were very expensive at the time, extremely expensive and not accessible by the rich people. But again, through PEPFAR, again, thanks to the US government for funding this became very available. And so we see improved survival of the HIV infected, meaning reduced incidence of orphans. But also if you have for your orphans, again, the issues of social disadvantages of orphanhood also are minimized, stroke dropout, and the pregnancies reduce. Maternal mortality also goes down because those who are at risk of having those bad outcomes, also the numbers significantly decline. But also the programs available are able to address the few. So this was a very important piece for me. So widespread uptake of interventions have significantly helped mitigate the challenges of orphanhood. Again, I continue to work with Professor Sentali from Colombia in this space of adolescence and orphanhood. And we have generated a lot of evidence and important information to further strengthen the services needed by those who are disadvantaged. Yeah, so we have been in the space of social reproductive health. And suddenly, having worked again in Rakai, I went ahead and looked at what every woman and man have a right to have the children they need and when they need them and how many. But of course, the programs of HIV, when they came in, those who were infected were being kind of persuaded to not have the children they needed because they would pass over the infection. But again, I went ahead and said, okay, so if women and men who are positive get onto ARTs, what does it mean in terms of their fertility? It was very clear in here. Those positive on ARTs have increased the pregnancy rates compared to those who don't get on ARVs when they're positive. So which was very important, certainly. And also went ahead and said, okay, the other thing which is a driving force for high fertility and pregnancies, of course, is the desire for children. So when you look at that data again with Hannah Brownwart, was a faculty in the department, again, desire of children, fertility desires were a big driver of high pregnancy rates. So then this told us that there is a need to provide the commodities, supplies, information to the women who need it so that they could be able to have the children they need when they need, even if they are HIV infected. Then there came a bigger aspect. The London Conference of 2012, the family planning, and many of you may recognize Melinda Gates at that conference, where one of the objectives was to say that governments and the agencies should contribute resources to ensure having at least 120 million new users of family planning commodities for those who need them, men and women. However, government is committed, but what was very important is we needed data to show whether the objectives of this funding of increasing and reaching the target was being met by monitoring key family planning indicators. And that's how performance monitoring for accountability, the first time it was called, later on changed for action, was birthed. And working with the Gates Institute at Johns Hopkins. And so we got into this space, and this has been working in 12 countries and generating evidence to show progress, but also alerting the countries where we work what they need to do, what is working, what is not working, because many of them have interventions, but then evidence generation was a problem to be able to know whether actually their programs are working or not. So PMA has been extremely helpful at a national level, program level, and even district level in supporting and helping people appreciate the efforts they are putting in family planning. So the leadership, many of you certainly are aware about the leadership, thanks to Professor Emicho, Emeritus, Scott, as well as currently Phil is in charge and managing and supporting us in managing the PMA, continue to generating useful, important evidence for family planning and for monitoring. In Uganda, when the funding was announced that it may not be available subsequently from 2022, the whole research program, Ministry of Health and Population, everybody kind of froze. And this is real because Uganda PMA has been one of and is one of, if not the only one, generating national level data on an annual basis to inform policy programs. And so this was not a very easy piece of information when we received it, but thanks to the leadership, because we got opportunity to do at least some surveys as we go along. So some research from here, again, we looked at the increasing trends in modern family planning in Uganda and other countries using this data. Very important also, we have been able to determine and know the unintended births are still high. Women with unintended birth, about 46%. However, those in the poor household is twice as high. And this information is extremely important because it also shows issues of inequality, disparity, but also potentially inequity in service provision, leaving the poor behind. But also data has been generated from this work showing that twice as many young women initiate union, child marriage in the rural compared to the urban. All this information has informed, as we shall subsequently see, the documentations that are important for enhancing program and service. Very important slide. We named this slide Jotham slide. Jotham has been the chairperson. He's the Director General of the National Population Council. We explained this slide, which shows the reproductive health indicators comparing rural to the urban. Summarize information very clearly. In a rural area, sex initiation is earlier than the urban. The number of children, the marriage is much earlier. First birth is much earlier. Contraceptive use comes right about the same age, but by the time women in the rural area use contraceptive the first time, they have about 2.5, call it 3 children, compared to about 1.3 or 1 child in the urban area. So this information was visualized, packaged, and the Dr. Jotham Musinguzi, the National Population Council Director, who has just retired, informed us, our team, that this was one piece of information he used in cabinet with the ministers to convince them about the disparities in reproductive health indicators and inequities in service provision, and the need to help the men and women, especially in the rural setting, who actually seems to be very disadvantaged. And the president was very happy. That's what he told us. And I think, again, PMA data and our work in this space has reached the highest office and helped us inform policy and programs subsequently. Recently, Uganda has just completed the Uganda Demographic and Health Surveys. And like I told you, the data we have been analyzing from PMA and other sources from other colleagues who are doing work also in maternal and child health here and Rakai HIV, like I've said, this national survey is showing a declining trend in total fertility, running from 7.4 in 1988 to down to 5.2. Again, the information which we provide feedback has been helping programs to put in more energies, monitor communities, monitor supplies, monitor their programs and messages. But we are seeing a decline. It's true even in other settings, but I should say this information provided has significantly contributed to availing information to do this. But very important, when you see the map of Uganda, there are some dark areas and light areas. Although there's been a decline in total fertility from 7.4 to 5.2, what is very clear, there are some areas which still remain with very high total fertility rates. Again, as we saw, is it partly due to desires, high fertility desires? Is it the inequities in service provision? Is it in the age structures? So we continue to do sub-analyses, again, to inform the programs that they can have targeted interventions All that and many other things that have been necessarily presented have informed the national strategic documents, costed implementation plan, and we have been part of the steering committee and for this documentation. We have been part of the family planning FP 2030 commitments, again, where evidence, again, from the research that we have been involved in has contributed to what has been documented here, even in population policy. And recently also, about 2 years ago, we supported the National Family Planning Research Agenda, the Ministry of Health. Again, evidence is drawn from the work that we have been doing. Having said that, there's so much elsewhere that, again, remains area of interest and importance. Africa, including Uganda, population is aging. Again, recent survey showed in Uganda, the life expectancy overall has jumped from 60, I think 64 to 68. So population is aging. But where are the services for the older people? The HIV infected persons have improved survival. They are growing with HIV. HIV has been associated with NCDs. So we need to start critically thinking and looking at the population aging and the services they need. Recently, I've just won a grant with my colleagues here to look at population aging, the unmet need for health care and social care for the older persons. So this is real in our setting. But also urbanization is significantly increasing in Uganda and comes with challenges. And again, there's a lot of urban poor. It's not only the rural, but also we have the urban poor. So we need to think about how to manage that space of the urban poor as well. Non-communicable diseases, about a third of the total deaths in Uganda are due to NCDs. But also I've said those who age with HIV, in addition to having NCDs, even in the absence of HIV, now this combination is not very healthy. So these are becoming very huge and important components, aspects that we need to be looking at. Climate change, biosecurity, that can't be left behind because it speaks to food security, it speaks to nutrition and many other. So these are some of the areas that, again, whose space we need to find ourselves getting into. The urban poor, like I said, the productive health services remain a huge challenge, huge disparities, huge inequities in service provision in the urban setting because of the urban poor being left behind. And what we saw recently, again, from the demographic health survey, total fertility rate seems to have kind of gone up a bit in the urban area, although it continues to decline in the rural. So what we don't know is whether, again, the wealthy ones are getting out of the urban area, the poor ones are coming in, and maybe they're not receiving the services they ought to receive. So again, we need to work on that. I would like to appreciate the partnership, the collaboration, the mentorship that I've received from School of Public Health, my Dean, Professor Rhoda, as well as Professor Eddie and other faculties I work with very closely. And of course, the Rakai Health Sciences Program, I indicated to you, Professor Ron Gray, Maria Wewa, David Serrada, Nelson, and the rest. Again, that's the other research space where I began work. They have done the training, the collaboration, the mentorship. And when the PMA started, I've been the lead with my colleague Simon Peter Shibira, and we are leading a team, as you see in that organogram. And we have about 120 research data collectors who have very beautiful stories. Some of them have gone back to school because of the funding from PMA they are able to save. Some of them have constructed small houses. There's somebody who has got a border, and she called it PMA. And somebody else has built a shop. I think I may want to get these stories and share them subsequently if I think we don't have them at Hopkins yet. So, but this team here has been fabulous. And what I learned in partnership, collaboration, mentorship, I'm also cascading that to my colleagues. And many of them actually have been able to go to school and complete their masters. Initially, they hadn't thought about that, but because of the encouragement, they have been able to do that. What a great collaboration and partnership. About just before COVID, I think Professor Emicho, he got in touch with us when Bill Gates Sr. passed on. And so we planted a tree in his memorial. Almost everybody on the team planted, but they agreed that I should be presenting mine. So from 2020, October, when the planting happened, up to the most recent, I was in my garden this week, April 1st. That's how the avocado tree is growing in the memorial of Bill Gates Sr. And this has been very good for us. And I would like to really thank you for this great opportunity to humanity. As you're saying, logo goes, all vision, saving millions one at a time. We've also been able to tap into that. Thank you so much for listening.
All right. Dr. Makumbi, thank you so much for that fantastic presentation. It's really just inspiring to see all the work that you've done, your accomplishments, and just again the breadth of experience that you have in reproductive health, family planning, and just overall public health in Uganda. So thank you very much. And in response to one of your last points, I would love to hear more about the stories of how people have benefited from their time on PMA. And it's just really great to hear about the Boda named after PMA. That's fantastic. So I'll reach out to you at some point to get more stories about that. So I'm looking at the chat, and it looks like we have some questions already. So Dr. Makumbi, maybe I'll read the questions for you, and if you want to answer, that'd be great. So the first question says, "Great presentation. How do you see future collaborations building upon the previous existing ones you mentioned? So how do you think we can move forward with future collaborations?"
So sure, thank you very much for the opportunity and for the audience listening in and the feedback we are providing. Yes, collaboration, some of the things I've been doing and continue to do is to try and identify the areas that are relevant and impactful to the health of the population. And once we identify those, suddenly we have worked with the Ministry of Health and the Bureau of Statistics and other key players in these spaces. And then we engage the other partners, like at Hopkins. We've continued to work with a lot of other colleagues. And recently there are two colleagues from Hopkins who are working on similar areas. One of them looking at in the area of fertility. And that has been very helpful because that remains an area that needs to be supported. So one, identify the relevant and important areas that need impactful on the population health, then engage the partners that you can work with, further strengthen the partnership, and also engage government because, of course, funding internationally has gone down significantly. So making sure that we involve government and private partners has been helpful. So, but also the training, very important, the training. And like in our case, as we have indicated, we have a lot of persons that we are supporting and mentoring, and that also help us to spread how important the work we are doing is. Another point of joining us and being, of course, responding to the many IR calls from NIH and other funding sources. So that's one way we have continued, but collaborations have been very important, remain very important.
Great. So the next question is, you have a lot of your research getting into practice and policy. Can you talk a little bit more about that? Could you help us understand how you were able to tie research with practice and policy in Uganda?
Yes. So coming from an academic setting, a lot of time we get excited suddenly when we do research, publish, and say, okay, we have achieved. Yeah, because we know in the universities, when you publish, it comes with promotion and many other things. But I think the ultimate is how important is your research to the population. And one way it gets into the population is if it can get into practice and policy. So how do we manage that? So many of the things that we do, when we have a research idea, we have been involving the Ministry of Health or the Ministry of Gender the Bureau of Statistics, those high-level stakeholders, we engage them as well as implementing partners who are providing service to the communities. We engage them, we discuss the protocols. Many of them end up actually including some of the questions of interest for either monitoring or understanding the services they're offering. So stakeholder involvement and engagement. And we have found ourselves also being a part of the technical working groups in the ministries of health. And that gives us sort of platform to hear what the other members in that sector are saying, but also to then tap into the ideas of what they want to know. And that also helps that when we are writing protocols, we engage them. We engage them in monitoring as well when we are running our implementation. And when time comes for dissemination of results, we sit with them, agree with them, and ask them what these mean in their sectors. And so when we are disseminating at a national level, we disseminate these findings as a team because we have involved the stakeholders from inception of the ideas to the implementation. And then that becomes much easier to have many of these recommendations built into the policies and practice guidelines. And this is very helpful. So that is not possibly offered in our training, but it's one of those soft skills which we need to learn and engage when you're conducting the research for it to be utilized in the settings where we.
Great. So the next question talks about contraceptive use and fertility in Uganda and actually more broadly in sub-Saharan Africa. So based on your experience in Uganda and elsewhere, the question is, sub-Saharan Africa still has a relatively high fertility rate and a young population, and contraceptive use and prevalence is relatively low. So what are your thoughts on what else needs to be done in the region to help to address the challenges posed by high fertility and low contraceptive use? What do you think are the most important things in research and programs that need to be done moving forward?
Yeah, so thank you very much again for that question. Yeah, I think just to give a disclaimer, every man, woman, and family must have the children they need and when they need them. But also, it's very important for them to have the information to make the appropriate decisions. So many people have viewed family planning programs as population control. And I think way back in the Cairo conference, that I think was, we moved away from that. And so realize the population we can tap into populations for development. And as you may recall, given the high population in Africa, we are looking at the demographic dividend. How can we tap into the young population? And demographic dividend, we can tap into the large population that we have of young people by not continuing to have very many, a very big population. We need to find a way of limiting or minimizing the unintended pregnancies. As you saw, nearly half of the women from the data had unintended pregnancies. So what else needs to be done to make sure we don't get into the public health challenges of unintended pregnancies, which are nearly half, which will result into large populations? Then it would mean multiple things, but some of the things that we need to think about is how do we equitably provide the service to the populations that need it when they need it. A lot of time when funding for most of these services come, not only family planning, by the way, we tend to have these services where the implementing partners have better access, because a lot of time implementing partners are judged on how many service people have been served, but not who you have served necessarily. So we need to make sure that the work we are doing, which I've been involved in the past 1 year, the work in the space of equity and disparity, making sure services are getting to the people who need it when they need it. So being able to conduct the analysis, flagging out the hotspots of populations being left behind by looking at disparities and inequities in service, that will take us a lot of mileage in getting populations who need the service. But also one of the contributors to fertility in Africa certainly has been high fertility desires. And this kind of has cultural connotation, but also it comes with the lack of development in socioeconomic development, if I may say. And I think there is increasing need and realization that empowering the men, but especially the women in these poor settings, will generate economic priorities that fertility then may possibly change appropriately because it becomes even expensive, as we know. So again, continue to do more research, flagging out the iniquities and disparities, and making sure services can reach, including information. And lastly, I've been recently involved in the area of self-care, where men and women can get the services they need by relying on their knowledge and understanding and minimal consultation with health providers once they have the knowledge. So we think that can also minimize the inequities. And lastly, we are looking at the high impact practices. For example, one of the opportunities that many women miss is post delivery. Very few are able to have immediate postpartum family planning. And if they miss out that opportunity, they end up having repeated pregnancies within less than the recommended period. And that balloons up again the issues of fertility. But so cutting down unintended pregnancies, empowering women in the communities, flagging out the inequitable populations and then providing service. I think that's one of the ways we may want to mitigate the challenge of high fertilities, primarily because of unintended pregnancies. Yeah. Other ideas are welcome, certainly, but those are some of the things that.
That's great. So the next question is about research questions. So what do you think are some important research questions that have not yet been answered in the Uganda context? So what do you think is some research that you would like to see done in Uganda in the future?
Yeah, I usually call it the challenge, but a good challenge. I'm kind of glad that my training is in statistics, and I find myself in a lot of spaces to support the numbers, the figures, the evidence. I love numbers because, well, some people, I'm told, can make them lie, but they generate evidence that we can use again to provide the services that we need. So one of the things that has been increased, there are many, but one of the things that has been intriguing to me, a lot of time, for example, we have been looking at urban and rural, and we think urbans are much better off than the rural. But what we're increasingly seeing, even from the recent demographic health survey data, the urban poor are significantly increasing, and there are significant disparities in the health outcomes, even beyond family planning indicators. So and because we have also been seeing a significant movement, mobility or migration of the rich ones, leaving the urban, going to the peri-urban and even the rural. So, and yet the urban are being left with the poor, and the health dynamics are different. NCDs, the issues of family planning, as I would say, hygiene, environment degradation, even within the city. So, and we are watching, unfortunately, but School of Public Health has engaged with some of the municipalities here, like KCC, Kampala City Council Authority, and others to start thinking through and see how can we be able to mitigate the expanding, potentially exploding urban poor population that needs service. Otherwise, if we don't address that, we shall get into issues and challenges. And there's been a number of projects that has been started running to address this issue. And lastly, quickly, the other one I'm seeing, and I spoke about it, the issue of population aging. There's increasing life expectancy, a growing number of aging population in Africa, including those who are aging with HIV. And of course, we have issues of NCDs. But do we have the systems ready to address the needs of the aging population? And if we don't act now, I think we are doomed. I don't want to scare anybody, but that's a fact. because we are not able to manage the young population, and here we are with aging population. So that area we need to be able to also to quickly make investigations. And as I said, we have begun looking at that area, the unmet need for healthcare and social care for the aging population. And I think those can quickly help us prepare for what has not yet fully happened. There are many others, but that's what quickly comes to mind based on the space I've been involved in.
Really interesting for Dr. Makumbi. Thanks a lot. And the next question you've answered to some extent already with your previous answer, but maybe just a focus on urban health. So beyond what you've just mentioned in terms of the disparities and some of the demographic patterns you just described, could you talk more about, is there anything else you'd like to say about your interest in urban health research and programs in Uganda and any other interesting trends that you're seeing, or did you cover that with the last your last answer?
Yeah, maybe so to broaden that, certainly recently Uganda, for example, has created cities. We used to have, I think, one city, not I think, one city, Kampala. But in the last 3 years, every region has almost got a city, a lot of urbanization, and no infrastructure, unfortunately. So the areas are being baptized and prepared to be cities, and there's a lot of in-migration, but also in terms of baptizing them. So, but also, as I've said, population aging, and we are seeing poor nutrition, poor hygiene, and of course, because of the rural moving to the cities, again, we get into the area of social reproductive health. So there's a need to strengthen the health systems to be able to manage the cities, urbanization, the cities. In cities, like I said, nearly a quarter of people are unaware about their status, even when they have these dilapidating chronic conditions. So there's so much, I think, that needs to be done in terms of laying the appropriate infrastructure in the cities, economically empowering them as well. And even as the richer ones are moving out, there's, of course, crime. Crime is another big one, which has been setting in when urbanization comes with crimes. And that is also a big issue, although there's still a lot of control on the guns. But again, those may start to come in and then you get into challenges. But then also pollution, which is again more common. So cities, health systems are kind of not ready to accommodate the growing urbanization, but also that is coming with the environmental degradation. Against a combination of things that I think needs to be thought through critically and see what's a priority that can be able to help mitigate challenges with others. So I think that's one area we continue to think through and see what else we can do. And reproductive health, of course, remains a big issue in a poor setting. Yeah.
Okay. The next question, how do you think civil society organizations can use the research to advance access and support for family planning information and services? So focus on civil society organizations and how they can help to advance family planning information and services in Uganda.
Okay, yeah, so great question. Interestingly, again, because of I think somebody asked the question how they practice and how we're able to put our research into practice and policy. We are working very closely with the civil societies, ministries of health and others. So many of them have engaged us on supporting them in monitoring their services they're offering to the communities, and especially the urban settings and even the rural. So a lot of this information has been very useful for them to fine-tune the implementation of their services, because they discover that a lot of times they are going to spaces which were not possibly necessarily in need of those services. So this information has been very helpful to monitor and help them direct their resources and programs where they could potentially be more effective. And we are seeing a lot of this really happening, turning around. A lot of the disparities are coming down in some areas where we have worked with them for them to monitor. And of course, they have also requested us to support them in analysis of data like the DHIS2, which is routine data, which you translate with the survey data. And again, this is to inform their programming. And this has been very helpful to them. And we continue to build those relationships. And the School of Public Health, for that matter, has been singled out as in charge of the M and E of many of these implementing partners, because many of them get the resources to provide service, but then data management monitoring was not one of those, but we have persuaded them and showed them the importance of information. But again, we continue to mentor their teams whenever they are available and work with them closely. Yeah.
Great. So next question is about research. So in your experience, how do you think we can best support junior researchers and elevate their research and publications? So any tools, suggestions would be appreciated. So focus on junior researchers and how to promote their careers.
Okay, good. What we have done in PMA teams, as far as you may have seen the team, many of them, the colleagues who came in, had bachelors, and we persuaded them to join and do graduate training. And so mentoring, you can't go wrong. So we need to hold their hands. At Makerere, we are making sure the students whom we train for graduate and even undergraduate, we hold their hands and we attach them to the projects on which we work, because then they can get the practical experience, and then we support them when there are grants that they usually the small grants that kind of come through the school, and we support them write these, but also we give them opportunities to make presentations. So my team, for example, when you're even disseminating the PMA work, I don't do the whole presentation. Again, we have supported them to give them the confidence to make the presentation. So holding their hands, mentoring them, and supporting their grant writing would be one way that can possibly push them into the area of research and practice, but also linking them to all these stakeholders whom we work with. And I can clearly offer my example. One of the persons I worked with very closely, and now people are looking after him to be able to provide them with technical support is Simon, whom again Phil knows very well. He's my co-team lead. Initially, he is a PhD, but again he did this PhD while on PMA. I supported him together with other persons, and now he has reached a level where he's also writing grants independently. But mentoring, holding their hands, and supporting them has been very helpful, and one strategy that possibly can work to further promote these their research capabilities and program.
Great. Thank you very much. So it looks like we're just about at time. But Dr. Makumbi, thank you so much for joining us today. It is just such a fantastic opportunity for everyone here to hear about your experience, your career trajectory, your research focus and programmatic and policy ties and accomplishments. So thank you so much for joining us today. It's been great to have you with us. We appreciate you taking the time.
Thank you so much for giving me the opportunity, and thank you all so much for everybody has been attending and the questions they have asked. These have been very helpful for me and my team, and we shall work towards addressing some of the issues that have been raised and continue working together. Thank you so much, Phil, and the Guest Institute.
Great. All right. Thank you.